So while we're encouraged by the progress being made in treating patients with BRAF V600E mutated colorectal cancer, there are still hurdles. I think one of the biggest hurdles is awareness, right? To make sure that patients really understand their tumor's molecular profile and making sure that that testing is done. And so always encourage patients to reach out and ask about their molecular profiling if that hasn't been shared with them already. The second is really understanding how to improve the activity of the regimens and the therapies that we have. While we're encouraged, for example, by the safety lead-in data and the Beacon study suggesting a 48% response rate and duration of progression-free survival of 8 months, there still is room for improvement, both improvement in the response rates but also the durability of control. And I think a lot of the questions that are in the field are, why are patients progressing? What are the mechanisms whereby the tumor is developing resistance? And then what are the novel therapies that we can use in combination, perhaps in patients with resistance, in order to try to extend the duration of therapy?
Some of the key future directions in BRAF mutant cancers and in BRAF mutant colorectal cancer include whether other more rare cancers that harbor BRAF V600 mutations actually may respond to BRAF-directed therapies. Really, colorectal cancer has been the primary example of a tumor type that is not responsive to BRAF inhibition alone or to BRAF-MEK inhibition. But what we're finding is actually an encouraging signal in other cancer types, such as lung, thyroid, and biliary cancer. And so there is potential that a BRAF combination regimen may actually be useful in a tumor-agnostic manner outside of colorectal cancer in BRAF V600 cancers. In BRAF V600 colorectal cancer, a lot of the future approaches really are focusing on not just increasing the initial response rate, but actually increasing the durability of response. And so what we're finding is that resistance basically across the board still seems to be involving reactivation of the MAP kinase pathway, either through adaptive signaling and reactivation by EGFR and other receptor tyrosine kinases, or by the very rapid emergence of resistant subclones that harbor other mutations within the MAP kinase pathway that are able to maintain that critical pathway signaling even in the presence of these 2- and 3-drug combinations. And so some efforts are being made to explore other MAP kinase inhibitors, such as ERK inhibitors, which may enter early clinical trials. This may both increase the degree of pathway suppression that you achieve during initial therapy, but also may help to suppress the outgrowth of these resistant clones. The second approach is to see if we can perhaps harness some of the promise of emerging immunotherapies in oncology, and see if we can actually engage the immune system to help delay or even perhaps suppress the outgrowth of resistant clones, thus increasing the durability of response. And one of the reasons that this is attractive in BRAF mutant colorectal cancers is about 20% of BRAF V600 mutant metastatic colorectal cancer also harbors microsatellite instability. And thus far, in colorectal cancer, patients with microsatellite instability have actually responded very favorably to immune checkpoint inhibition, likely due to the tremendous number of mutations and the large number of neoantigens available for the immune system to recognize. And we actually have data that BRAF targeting alone may actually augment the immune response to colorectal cancer. And we have data from prior trials showing that patients with microsatellite instability who also have a BRAF V600 mutation can often achieve a durable response to BRAF targeting alone. And so what we hope is the combination of these agents will have a very important and durable effect in patients with microsatellite instability and BRAF V600 mutations, but this potential synergy may also carry over to patients who have microsatellite stable disease with BRAF V600 mutations. And there are actually now ongoing trials looking at combining immune checkpoint inhibitors with BRAF-directed combinations. And we're excited to see how those pan out.
So we're very intrigued by the potential to move BRAF-mutated therapies into other settings. One of the areas of unmet need is in the adjuvant setting, where we know that patients with microsatellite stable but BRAF-mutated tumors do have shorter disease-free survival, higher relapse rate than other patients. So it's another unmet need for the population. So trying to understand how to move this into the adjuvant setting, I think would be a worthy goal. It requires a large screening effort, but the potential to really benefit patients and increase the cure rate is certainly a worthy goal.
I think BRAF V600 colorectal cancer is an example of how close integration of laboratory science, clinical science, and translational medicine can really lead to tremendous advances in patient care. And it's really been this collaborative understanding of why BRAF inhibitors are not having an effect in BRAF V600 that has led to the discovery of several resistance mechanisms resulting in some of the current therapies like the Beacon regimen. And thus, by actually targeting these scientifically driven resistance mechanisms, we actually are improving patients' response to therapy. And we're hoping as the field moves on that continued discovery will help fuel further advances for these patients.